like to introduce our keynote speaker, guys. Dr. Tiffany Shubert is a physical therapist and PhD and Master of Physical Therapy. She graduated in University of California in San Francisco and PhD in Human Movement Science from University of North Carolina in Chapel Hill. And she has more than 20 years experience, and she do some lectures and pre and post DPT programs. She even have a great research and founded research with 35 peer-reviewed publications. If some of you knows what is Otago exercise programs, she is the one behind that, and she led the disseminations of the Otago exercise programs. So would like you to check it out and do some certification on that. That's wonderful for your patients, especially for fall balance prevention, okay? So for tonight, the topic for her is fall risk management, interventions, and updates for physical therapists. Our objectives for discussion for her presentation will be to describe evidence-based fall risk management intervention for each practice setting, determine appropriate intervention given clinical presentation, and discuss practice and the different factors out of scope of PT. All right. So without further ado, I would love to share this floor to Dr. Tiffany. All right. Dr. Tiffany, you're already a co-host and you can share your screen. Thank you.
Awesome. Thank you. Thank you so much, Dr. Youssef. This is super exciting and excited to be here. If you all have, when you have questions, just put them in the Q&A and I'll make sure I have time at the end. I will try to answer them in real time, but sometimes it's a little tricky with Zoom to do that. So I'm going to go ahead and pull my screen up and we'll get the show on the road. And we are going to cover a whole bunch of stuff. So there we go. All right. All good. Okay. All right. So as we said, we're going to really going to be going more through updates of what's going on in fall prevention and fall risk management. And I actually flipped the objectives just because I realized that talking about the risk factors out of scope is a better place to start the conversation. And I really want to challenge everybody on the call to be thinking about the fact that, as being a doctor of physical therapy, it really means that we have to look at our patients very holistically. And we also need to start thinking about this transition from an episode of care where we see our patient, we help our patient, we get our patient to where they need to be, and then we leave our patient, versus a continuum of care, because we all know with older adults that, especially with falls, like those risk factors don't go away. So how can we best engage our patients and empower them to help them manage their own risk factors? So we'll talk quite a bit about that. So here's what I really want you all to take away from our talk today. I usually start at the end, at the beginning, which is backwards, but it just helps get everybody on the same page. The most important thing we really need to be doing is screening all of our older patients for fall risk. And that means even if they were not referred for falls, even if they say they have never fallen, it needs to be part of what we do. I think of falls as a chronic disease. So as if you take blood pressure on a regular basis, you should be doing fall screening on a regular basis. And then keep in mind, and I know we all know this, but sometimes we forget that those risk factors are going to change depending on where that patient is in their life. So a 65-year-old is going to present very differently and have very different risk factors than a 95 or 100-year-old. And of course, that's not everybody ages the same way, but, we just have to be thinking constantly about where that person is in their functional journey, and talk a lot about self-screening and teaching our patients to actually screen themselves. So, and then remembering too, as cognition changes, mobility will change. So again, making sure we're constantly changing our intervention to match where that patient is. And I think where people sometimes get a little stuck is that, we want to be evidence-based and we want to follow the research, of course, but sometimes it doesn't apply exactly to our patients. So then our job as clinicians is to figure out what pieces of that evidence-based intervention are going to apply to this specific patient. And then, of course, team. And this is the hardest part, right? Especially right now practicing in the United States, because there's so much change happening and we have so much turnover, but we need every single person who engages with that patient to be on the same page and everybody vested, including the patient and their caregiver, in fall risk management. So let me get the show on the road here. So here's what we're going to do first. We're going to talk about some of those best practices for risk factors out of scope. And the reason why I want to talk about doing this is because there are certain risk factors that patients have when they come to us that we are not prepared to treat. And if we do not triage appropriately, we are doing that patient a disservice. And I'm sure you all are thinking, what? But like cognitive impairment, if you have someone with significant cognitive impairment, you know, we've got, and it's not being treated, or if you have someone who has significant depression. So we'll talk about that. So screening versus assessment. This is really, really important, and it gets really confused. So a screen is something that does not require specialized training. And I'm going to keep going back to blood pressure because I think that's something we all understand. So I right now can walk into my grocery store and I can put my arm in a machine and it'll tell me my blood pressure. All right. I don't need a doctor to do that. I don't need a nurse to do that. And then I get that information, I get those numbers, and then I can go back to my healthcare provider and say, hey, I got a problem here. So screens tell you that something is wrong, but it doesn't actually tell you what the problem is. Blood pressure is high. We don't know why it's high. And that's when we need our clinical experts to step in. So, so screening is really important. And we have a lot of wonderful screens out there, not only for falls risk, but for cognition, for depression. And those are screens that we can do, even if it's out of scope, because it's a screen. But then we can't really act upon it again if someone has cognitive impairment, but we can at least identify. And then assessment, that is really something that requires that clinical expertise, not only to conduct the assessment, but to interpret the assessment. And the assessment is going to tell us more about the why. Why did this, you know, this person has, they got a 16 on their timed up and go, 16 seconds. So I'm going to do a deeper dive. I'm going to do a thorough evaluation and assessment and understand, is this because they've got knee osteoarthritis or a knee OA and they're recovering from pneumonia? So, but that assessment is so critical because that's going to give us the objective data that we need to guide our intervention. So a couple things to be thinking about. I'm going to do a little deeper dive, but falls, of course, are multifactorial, right? And every patient has a different combination of factors that are contributing to their fall risk. And when we think about what we can do as PTs versus who we need to be referring out to, okay, strength and balance, definitely within our scope, right? And we all know that as we get older, we've got sarcopenia, it's the natural process of muscle wasting. We've got to be educating our patients about doing strength training. We also need to be challenging our patients. You know, even though they're older, we can't break them. They need to be doing, you know, percentage of 1 repetition max, high intensity strength training to really get the benefit. We can do all that. We can manage the physical activity. We can address the balance impairments. Comorbidities also contribute, right? And they get all mixed up with the strength and balance. And this is where sometimes we can manage some of the outcomes of those comorbidities, but we also need to be making sure if we have a patient who has diabetes that's not controlled, who has long COVID. This is a huge, huge issue right now. I'm starting to treat a lot of patients who are experiencing these long COVID symptoms, and we need to be aware of those symptoms. I'm sure you all, if you have experienced this in your clinical practice, these are those patients that show up and you have a moderate intensity intervention with them, and then they're like wiped out for 4 days. So they have a very different response to a lot of our interventions than other patients. So we need to know what those comorbidities are and identify them and engage the right healthcare provider. And of course, polypharmacy, this is everybody's challenge, right? We've got patients taking all sorts of medications, and we need to be aware of those meds and making sure that if they are on a medication that could be increasing their fall risk, that we're engaging either their physician or the pharmacist. Sensory impairments, of course, whatever we can manage, but then making sure that we have access to other team members who can address any major vision issues, hearing issues, proprioception issues. We can manage the vestibular issues, the cognitive piece, and then the lifestyle piece. So all of these, this is like our little, snapshot of those risk factors. And our job is to figure out what's going on with this patient, what risk factors do they have, and then triage appropriately. So for example, if I have a patient who comes to me and they score really high on their PHQ-2, which is a screen for depression, I kind of know that I don't know if this is the right time to start physical therapy, because they actually may be too depressed to engage. So maybe this is the time that I'm going to go back to the referring physician. I'm going to engage a social worker, and let's see if we can get that depression treated to the point where that patient can engage with therapy. Because if you think about it, if you're depressed and then all of a sudden the therapist is telling you to do all these things and you're too depressed to do those things, then you're feeling bad about yourself and then you're getting more depressed. So you want to stop that cycle, nip that right in the bud. I am going to talk briefly about some different screens that we're using, and I do have some screens that are definitely more specific to the US population, so just bear with me on this one. So I think people are familiar with the STEADY, which is the Centers for Disease Control fall screen. This is really an appropriate screen for folks who are independently mobile, so people who are seeing more in an outpatient setting. Not so much, definitely not for acute. It just doesn't really work. If you've ever tried it, you're like, no, I mean, we've got a bunch of other folks who are working on some of the other risk factors, and my patient isn't mobile enough to do the test. Can work for some folks in home health, but it really is designed for that outpatient setting. And so when we can do every component of the study, it's a multifactorial screen. We can learn a ton from it. And then we can do our screening tests. And that would be for the study, the timed up and go, the 30-second chair rise, and the 4-stage balance test. And again, that's going to quickly tell you, hey, this is somebody who's got some balance impairments, has some mobility impairments. We need to be doing something and do a deeper dive. This is a little cheat sheet I've put together. And this is in the handout. But basically gives you a sense of, okay, if this is the problem, here's when there's if I've done this screen and I've identified this impairment, here's what I need to do next. So, and it's all really straightforward, but they fail any of your mobility tests, then you're going to do a deeper dive with the appropriate balance assessment. Meds, you know what to do. If we're hypotension, big problem. If you've got an patient who's orthostatic, meaning that they've got a drop of greater than 20 diastolic, 20 systolic or 10 diastolic when they do positional change, we need to get on top of that right away, because that's really going to result in a higher fall risk. Vision, feet and footwork, vitamin D, and comorbidities. So just a good little cheat sheet for you as you're working with these patients. I think the biggest mistake we make as therapists that I've seen is feeling like I'm not comfortable with a cognitive screen, therefore I'm not going to do it. And that's a problem, because we actually do have that FaceTime with our patients. And it is absolutely okay for us to do a mini cog, which is just really simple. It's a 3-item repeat, a clock draw, a 3-item recall. And, if they can't draw a clock, or if they can't remember 1 out of 3 words, well, that's positive for a problem with cognition. And just doing that, it literally takes a minute. Calling the physician, all of a sudden you really made a huge impact. Even though it may not be using your musculoskeletal skills, you've made a huge impact that now you can get that patient the right intervention so that when they're ready for you, you can do something with them. I do want to alert you all to kind of a really cool and free tool that's available on the National Council on Aging website. It's called the Falls Free Checkup. And I love this tool. So anybody can use it. It is a virtual translation or an online translation of the Stay Independent brochure, which is also part of the study toolkit. It's an evidence-based self-assessment for fall risk. And the thing that's great about it is that it asks a series of questions. You know, have you fallen in the past year? Has somebody told you to use a cane or a walker? Do you take medications to help you sleep? And it's all patient-facing language. And the older adult goes through, answers the questions, and when they're done, they get a report. And what's in the report is the risk factors. So if you said, yes, I use medications to help me sleep, the patient will get some education saying, hey, just so you know, oftentimes some of the meds that help you sleep will also increase your fall risk. It might be a really good idea to talk to your physician and maybe get on a different medication. So I use this with my patients a lot. I bookmark the website address, and I actually have them, and I get them to the point where they go on a regular basis, like once a month, because it also will generate like a report they can take to a healthcare provider. So this is a great resource. If you have an older adult, if you have a patient who isn't comfortable with technology, not a problem. A caregiver can do this with them. Anybody can do it with them. But again, really great resource. It's free. It's available anywhere. Really, really good stuff. All right. So now we've talked a little bit about outpatient. Now we're going to go a little bit more into home health settings and skilled nursing. And of course, depending on the setting that you're in, you may not have to do a multi-factor screen, because you may have other team members who are covering parts of that screen for you. But no matter what, as the physical therapist, you got to look and see what other people have done, so you can start synthesizing all that information and getting a picture of that patient. Now, to be clear, you don't need to repeat. I know sometimes we get into this, oh, we gotta, you know, if another member of the healthcare team, you know, took a medication review, I'm going to do my own because I need to do it. And no, we need to streamline, we need to triage, we don't have time to repeat work, but we have to look at what our team members have found, our colleagues have found. So what I have here, and again, this is definitely more US facing, is when we look at all of the key risk factors related to falls, and when we look at some of the standardized documentation we need to do given the setting, where can we kind of cut corners a little bit? And when I say cut corners, I'm not saying we're giving up quality. I'm saying we can look and see what other people have collected data on, so we don't have to do it twice. So with the study, we know that whoever does the study, you get all of this information, and you know, you're set. With the OASIS E, there's information that the physical therapist can collect if they're not opening the case, and it's gait and strength and balance. There's information that the OASIS collects in general that we can review, so we don't have to go back and ask those questions again. And that's where those X's are. The question marks are, they probably don't review. I mean, to the best of my knowledge, the OASIS doesn't have anything about feet and footwear in it. And same thing with MDS. So this is just a really nice way that you can look to see if someone else has completed all that information, take a peek at it to get a sense holistically of what's going on with that patient. Yeah, and the pro tip here is look at section M1033, that it'll tell you a ton about the fall risk factors if you weren't the person opening the case. So just a little bit more, when we're in skilled nursing and long-term care, you want to look at on the MDS data, sections A, B, G, G, I, and J for risk factor data. Give you a really good sense. And I got to tell you, most patients, and you all know this, who are in skilled nursing or in long-term care are already at super high risk for falls. And they're the hardest falls to prevent. But again, I always find, even with these folks, that there's always a risk factor we can address, or there's a medication that can be changed, or there's something that can be done that can either maybe not prevent the fall, but definitely prevent the risk of experiencing a fall. One of the things I wanted to call out is there was a study that was published earlier this year that looked at a huge database of folks in skilled nursing, and what they found, and this is no surprise, but the key predictors of a fall with injury were gender, female, age, okay, of course, vision impairment, cognitive impairment, ADLs, orthostatic hypotension, diabetes, and history of hip fracture. These are all things we know. It's always good to validate, like, but just know that the data is supporting everything that we already know. And then in home health, OASIS E, you're going to look at sections B, C, G, GG, and J, and that'll give you a really good comprehensive view of that patient's risk. And in home health, that's probably it's so important just because you don't have that team on site to care for that patient. And then what we're seeing when you start looking within the home health data, it's kind of interesting. The big predictor is age, of course, pain. So it's interesting, folks with less, I always get this reversed because the data is counterintuitive. Folks with more pain actually fall less. And the reason being is that if they are in more pain, they typically are less mobile. Not to say that we shouldn't tell our people in less pain not to move, but it's just something to note that, again, when we think about how patients present, if they're super sick, if they're in a lot of pain, they're probably not going to be moving, they're going to fall less. The folks we want to really make sure are safe are those who have less pain and are more mobile and maybe not as balanced as they should be. And we also found that if you combine age, pain, and frequency of therapy, that actually is a more accurate predictor of who's at risk for experiencing a fall than the MAC-10, which is currently one of the standardized falls risk assessments in OASIS. And then if really walking speed is going to be the most important thing you could ever do with your patient. That's going to just give you so much information. So sometimes you get really stuck in all the data and stuck in all the paperwork, and we kind of lose sight of just looking at that patient, which is what we get to do as physical therapists, and assessing their mobility. So walking speed, I'm going to talk a little bit more about that. It's going to be your bread and butter. And then, of course, an outpatient, we covered this already. But definitely always ask about a falls history if you have the ability to send them to do the falls free checkup and do the steady test. I will tell you everything you need to know. So walking speed, again, like it's such a powerful indicator of that patient's function outside of their time with you. So this is a pretty classic piece of data and paper that's referenced on everything that we know about patients with their walking speed. But the rule of thumb is if it's 1.0 or greater, they're probably doing okay. We know if they can walk 1.3 meters per second, they can ambulate safely in the community, they can cross the street. Once you start falling below that magic number of 1.0, the patient is not doing as well as they should. Once you're below 0.8, your chance of experiencing a fall gets really, really high. Your ability to ambulate in your house is limited. So we know already that if they walk slower than 0.4 meters per second, they really probably shouldn't be discharged home unless there's care there, because they're going to be limited to walking in their house. They can't safely ambulate in the community. So if you have no time with your patient, and if you need to make a decision about where they need to go once they're done with the hospital, you've got to do a walking speed. And the beautiful thing too is that when you document the walking speed, there's so much data behind it that you're really prepared to have a conversation with your care team, with a physician, with an insurance payer who may be saying, no, this person's doing fine, they need to go home. Like you pull up this chart and you're like, no, I got to tell you, they're at 0.6 meters per second. This indicates that they're at a super high risk for experiencing a fall, that they're very high risk of not being able to actually ambulate in the community, and this person lives by themselves in a 2-story house. So, and it's that kind of data that we need to have those conversations. So just really, really, really great tool. And then if you've got a little more time, of course, the timed up and go. Time to go as a cutoff. They always say 12 seconds. I always document the time, but I always learn more from the time to go by just watching the patient. How did they get up from the chair? How are they ambulating? How are they navigating? And this is really the beauty of the time up and go. How are they turning? Are they safe when they sit? And then finally, the 30-second chair rise. We've got great normative values, age and gender-based normative values for that. Great snapshot of that lower extremity strength. And then finally, the four-stage balance test. A couple really great papers have come out recently about standing on one foot. Again, one of my favorite screens. If you can't stand on one foot for 10 seconds, you got a higher chance of not only experiencing a fall, but also experiencing dementia. And it's just such a great home exercise program, so it's like, there are very few things that you can do that are like an assessment and intervention and a home exercise program. Single leg stance and chair stand. Those are the two that click all those boxes. So that was just a really brief overview of screening and making sure that we're all super confident as to which other disciplines we need to be engaging and referring to when we identify a problem with our patient. Again, because falls are so complicated and multifactorial, as PTs, we cannot manage every single risk factor. We've got to leverage our team and our community. So we're going to touch upon the different evidence-based interventions for the different practice settings. I'm going to go a little bit deeper into building a continuum of care. So that is really looking at what happens to our patients when they're done with therapy. So best practices for all of your patients. Obviously, you're going to collaborate with your team. You're going to hear this a lot. You got to also triage with your team, like what really is the most appropriate time for rehab therapy to begin. Like, is that patient at that point, are they immediately status post hip fracture and we need to get them up and going right away? Are they still recovering from pneumonia and unstable? Do they need something else? Is there something else going on? Are they delirious? Not a good time for therapy if they're delirious. So, and then you're going to figure out which objective assessment you're going to use based on their clinical presentation, and that's going to guide your intervention. I'm really going to stress the vestibular dysfunction piece, very much underdiagnosed, especially in our patients with cognitive impairment who may not be able to tell us they're dizzy. So definitely screening as all patients, honestly, unless, if they're completely asymptomatic, that's a whole other issue, but really starting to realize that the vestibular issue in folks with cognitive impairment is huge. And then really from day one, engaging with your patient that, hey, this is your chronic disease to manage for the rest of your life, and here's some things you can do. All right, so my slide went backwards, so hold on, Eric. Okay. So there was an outcome measure toolkit published by APTA Geriatrics in 2021, I believe. Kind of interesting. So they went through and they identified that there were 108 falls risk assessments that had been published. And of those 108, only 20 were identified as having sufficient evidence of psychometric properties. Okay, so that means they were reliable. You could repeat them and get the same outcome. They were feasible, meaning you could actually do them during a clinical visit, because as researchers, and I can say this because I am a former researcher, sometimes we do these things that you can never do in clinic. And then all the items were valid. So I think that's really important. Okay, because we only have 20. And then of those 20 that were listed, the following have limited evidence related to falls risk: the 30-second chair stand, the four-stage balance test, the MAC-10, and the tug. So what the heck is going on here? So a couple things. One is, as PTs and in the PT literature, we have gotten very focused on developing assessments to predict falls. And the fact of the matter is, we actually can't and shouldn't be doing that. We should be creating assessments for balance and assessments for strength. But because falls are complicated and there's so many risk factors, we can never create the perfect assessment as PTs. We might at some point be able, to create a multifactorial assessment with great cutoffs that are going to, tell us that somebody's at risk for falls. But our tools really tell us what the different impairments are that are contributing to falls risk. So 30-second chair stand is a great test. It tells you exactly how strong your patient is in comparison to their age and gender-based normative values, and if they need to get stronger. So of course, if they're weak, that's going to be a risk factor for a fall. Same thing for this 4-stage balance test. So I always like to sort of pull it back and ground it and like, what are these tests actually telling us? And how can we use that information to build great interventions? So, and because I think people get kind of frustrated because it's like, oh, my patient scored, a 50 out of 56 on the Berg, but yet they still fell down and broke their hip. Well, yeah, maybe I had some vision impairments and maybe they had 2 glasses of alcohol, and didn't see something because they were a little inebriated, so there's all these things that we need to just be a little bit more aware of. So this is a mantra of mine, but assessments need to be patient specific, not setting specific. And the reason for this is in kind of this push to standardize outcome measures. And it's important to have standardized outcome measures, but I think we've kind of gone a little too far. And sometimes we ask our colleagues to do falls risk assessments on every single patient, but it's the same assessment for every single patient, but that doesn't really make sense because every single patient presents differently. We have 108 assessments, right, that are proven. So really important that we make sure that looking at that patient and that patient's abilities, we choose the correct standardized assessment. And this gets a little tricky, right? Because in home health with OASIS, you have to do certain tests. Use your clinical judgment, do those tests, pull up from it what you can. But if you feel like you need additional information, go for it. At the same time, doing a 10-meter walk, a 25-foot walk, a tug, and a 2-minute walk feels a little redundant. So, it's really up to us to kind of identify what all we need to be doing. So our tools are going to tell us the impairments. Not going to tell us about those other risk factors. That's why we start out with those screens. And we're going to use those objective measures to identify those impairments and guide the appropriate intervention. Okay, so, oh goodness, I'm sorry, that slide should not be there. There we go. So I was just going to walk through real quickly, kind of like the top assessments that we tend to see using quite a bit. The Berg, obviously everybody's aware of the Berg. We see it a ton and it's great. It's going to tell you a ton about those static balance issues, the functional mobility challenges. It's not going to tell you anything about vestibular issues, so if you're doing your Berg and the patient is complaining of dizziness or the symptoms are not lining up, that's your red flag. Hey, it's time to, I got to do a deeper dive and see what's going on with this patient and their vestibular issues. Used in all settings, it's a great tool. It can be a little challenging for folks with dementia, so it may not be totally appropriate for every patient with dementia. Isn't going to be really helpful if you've got a patient who's got some significant polypharmacy, vision impairments, orthostatic hypotension. The cool thing is the items are function-based, so you can pretty easily incorporate, build your treatment off of the items they scored poorly on. And you can incorporate that into your home exercise program. And you can really make sure that you're seeing objective improvement. So, but again, I'm just challenging you all as you think about it. Oh, I do a Berg on every patient. Why? Does every patient need this test? Are there other things that we should be thinking about first or second? And then the mini best and the brief best, love these tests. They are fantastic. They really provide great information about building targeted interventions. So it's really going to give you good insight onto a specific impairment, postural control issues, sensory orientation, dynamic gait, vestibular, It's really going to give you the biggest bang for your buck. It does not provide strength and endurance data, but that's okay. We can figure that part out, right? Can be used in all settings, but again, maybe a little bit more challenging for those folks with cognitive impairment, and may not, again, very similar to the Berg, certain patients, it's just not going to be appropriate for, because you're just not going to get good data. And again, you can see objective improvements. So other assessments, again, very much patient driven. The DGI is really a great test for gait impairments. It's not going to be perfect for every patient. The POMA is kind of interesting. It is not a great predictor of falls. In fact, Mary Tonetti, who created the POMA, has even come out and said nobody should be, this is the first kind of test that she created. It was early on in her career. And it's not super reliable, and it really isn't a good predictor. So if you are using the POMA and you're like, I feel like I'm not getting anything out of this, that might be why. Kat said you can get great information about sensory impairment. SPPB, again, it gives you good data about functional mobility. So just, again, really questioning what you're using, why you're using it. And like with the SPPB, I love the fact we get these numbers, but I feel it's almost a screen. Like I have a really hard time like building an intervention from the SPPB, like besides working on chair rise and working on tandem stance. Like I feel like, I really I want more information. I want to go deeper. Self-report, always helpful. And then the 4-square step test is also really good. Just coordination and inhibition. Again, you can just learn a lot from these. So when we think about our assessments, you're going to use that total score. That's really going to justify the why of the therapy in our documentation when we're talking to our colleagues, when we're talking to our payers. Hey, this patient scored 40 out of 56 on the Berg. Here's what this actually means. Yes, this patient is super high risk for falls because of these specific impairments. This is how I can help. And then also that's going to really guide your intervention. So that item score, that individual item analysis, that's really for us. So when we think about this, that total score is for the rest of the world to understand. That item score, that is how we're going to build our interventions. And we're going to build specifically to those items that they scored poorly on. So, and then when we think about those interventions, of course, if it's a vestibular issue, you're going to treat the vestibular impairment. When we're looking at the strength and balance, all of the research shows that we are not pushing our older adults enough. We really need to be doing high intensity strength training. We need to do a 1-rep max. We need to be making sure our interventions are, when we're first starting, if they're more frail, should be about 40% of that 1-rep max, working up to 75%. And it's okay for them to be sore. All good stuff. So, and again, I just want to call out that vestibular screen. We can absolutely screen for vestibular dysfunction on patients who are experiencing dementia. Got to just be, very mindful, very intentional. But we're starting to see in some different intervention trials that when we start screening the folks with dementia for vestibular impairment, the rates of vestibular impairment can be up to 50%. And when we treat these folks, they are doing much better functionally and falling much less. So just pay attention. If that patient seems to be like, this doesn't actually look quite right, there might be a vestibular issue. Don't be afraid of that. So I have a couple just little cases, and then we'll talk about some of the evidence-based programs. So here we got Albert. He was discharged home after a stay in the hospital with pneumonia. He has long COVID, and so he's got what we see with Albert's long COVID is that his resting heart rate is higher than it should be, and he has reduced heart rate variability, which is kind of one of the cardinal signs. He also has type 2 diabetes. Sort of given his OASIS, you can see like what are some of the red flags on the OASIS items that would be contributing to his falls risk. And in addition to that, he does have some auditory challenges. He's got some difficulty hearing, which is also contributing to his falls risk. So you're going to see him, you've looked at his OASIS, and you know that you've got to assess for this orthostatic hypotension because you don't have that data. You need to assess if he's got vestibular issues. You're going to check out his feet and his shoes. And of course, you're going to do bread and butter stuff, the objective assessment of gait, strength, and balance. All right, so here's what you find out. His tug is too slow. Excuse me. He can't get up out of the chair. He cannot stand on one foot. His falls free checkup, he scores at risk. If you score anything, it's anything less than 10 or less, you're at risk for falls. Positive for orthostatic, he's on some high risk meds, and he's positive for BPPV. So what are you going to do first? All right. So first of all, let's figure out what's going on with this orthostatic. Let's figure out what's going on with the polypharmacy. You're on the phone, you're figuring out like what meds could potentially be contributing to this, alerting the care team. And then you're going to go ahead and treat that BPPV because that'll like immediately, hopefully, make a difference. And then once he's a little more stable, you're going to do that mini best test. So after 2 weeks, it turns out that the hypotension was due to polypharmacy. One of his meds was interacting with his long COVID symptoms. So those have been modified. He's normotensive now. He's feeling much better. His BPPV is better. And he is starting to understand his symptoms and being aware of his symptoms and how he can possibly start to manage them. You actually put formal therapy on hold besides treating the BPPV. So you didn't dive into the balance issues or the strength issues, obviously, because of all the other issues. The mini best was not the right test for him. It was too challenging. So you did the Berg. And now your therapy is totally predicated on addressing the impairments identified in the Berg. So at discharge, he's independent of all those measures, has improved his Berg significantly. He's hit that MCID. He can stand on one leg. And then you're just going to recommend that as he goes to outpatient, he can do the mini best and get a little bit of a deeper dive into some of the different balance impairments. So, and he understands, like he's seen the improvement. You've engaged him the entire time. He understands why he needs to be doing his strength and balance exercises. And they're excited. He and his partner are doing the falls free checkup as a couples exercise. And they're doing it monthly because they also understand that falls risk factors can change pretty quickly. And he's going to keep going with therapy after home health. So he's going to transition over to an in-home Part B provider and also do some tele-rehab. He's very comfortable with technology, so it's going to work for him. All right, so let's talk about some longer term things. So I talk about this a lot, about this continuum of care. And I think a lot of times when we discharge our patients to an independent home exercise program, it looks like this for our patients. Like they're not really sure where they're going. It could be a little dangerous. What if I fall down during this exercise? I don't understand where it's going to take me. I can't see the other side. When we really want it to look like this, it should be open and beautiful and engaging and clear. Like if I do this, I will get from point A to point B. And it doesn't happen for everybody. Like this is, no fairy dust here. Like, of course, not every patient will end up there, but it really makes a huge difference. So this is really this is our goal, right? So, we work with them in therapy. We've treated their risk factors. And then we started on day one that, hey, your goal is to get anywhere between 2.5 to 3 hours of strength and balance training a week. And of course, people go, oh my God, that's impossible. It's way too much work. But you work up to it. And we know, and the data definitely shows that the older adults who are doing 2.5 to 3 hours fall less and experience fewer fall related injuries. And oh, by the way, when you do that, you also check the box for hitting the weekly exercise guidelines by the CDC and by the American ACSM. So when we're done with therapy or as part of therapy, we're going to transition them over to the appropriate program, right? And now, we could give them the pen and paper home exercise programs, but there's so many great online programs as well, especially if your patient is a Medicare Advantage patient. There's a ton of resources that they can access. And especially if you're working with them in their home, it's really easy as part of your treatment plan and sit down with them if they're comfortable and if they have access to the internet, and set them up on a program as part of your intervention. Because if you do that, hopefully they will have greater adherence and compliance. But we call this a warm handoff. So we're really finding the right program for them, and then we're helping them access that program instead of, hey, go, bye-bye, have fun. And then we're really going to make sure they're independent with it, and also that they're achieving that dose of therapy, a dose of strength and balance training. And this will really kind of help them understand that, I mean, we all know we've got aging population. It's estimated by 2040, I think, by 2030, 20% of the US population is going to be over the age of 65. You know, we've got other countries that are already at that tipping point where we have so many older adults. And so that means that we can't take care of all of them. We need to empower the ones that can to care for themselves. And this is a great place to start. So really briefly, evidence-based programs, these are, if you're not familiar with these are programs that have been validated and tested and proven effective in a randomized controlled trial, and then the same thing in the community. So these are programs that they're quality tested, they're guaranteed. These are typically not offered by physical therapists. Some are online, some are in senior centers. And they're really wonderful wonderful programs to refer to and partner with. This just gives you a little bit of a sense of, and the Otago program is an evidence-based program, and I will get to that in just a minute. But this just gives you a sense of that these things are relatively new. They kind of like entered the public health arena in the mid-90s and have grown from there. So y'all may have heard of Stepping On or Matter of Balance, or of course Tai Chi, but specifically Tai Chi, Moving for Better Balance. And these are all programs that are packaged and designed to be delivered a very specific way. And again, not necessarily delivered by PTs. We actually aren't typically paid to deliver them. Some are actually designed to be delivered by lay leaders. And so they can be really kind of a nice way to expose patients to really good programs, usually typically inexpensive or free, and also get some socialization going. And just so you know, there's a ton of programs out there. I've got a link in the handouts, but there's over 73 evidence-based programs. They're not all fall prevention programs. Several are, and I'll talk about those, but they also have chronic disease self-management. They've got programs for depression and medication and alcoholism. So there's a lot of really good resources out there. The other thing you will hear about are called best practice programs. These are programs that are composed of evidence-based components. They just haven't been tested in entirety. The reason why I bring this up is Silver Sneakers is considered a best practice program, and many of the programs at the YMCA. So these are fantastic programs that, again, very accessible, really easy to make that transition for your patient. So a couple of just examples for you. So going back to those Medicare Advantage patients, I am not promoting Medicare Advantage plans, but the fact of the matter is that over 45% of Medicare enrollees are enrolled in Medicare Advantage plans, and that number is projected to increase. One of the cool things that they do provide, it's not well advertised, is that 98% of Medicare Advantage plans offer a fitness benefit. So this means your patient can access fitness programs for free. This is a big deal. Unfortunately, they just don't know about it. So this is kind of a nice opportunity for you to do a little education. And they've also, years ago, Silver Sneakers used to have this like one exercise program, and it was okay. It wasn't great. They've really revamped them, so now they have much higher intensity, much more selection. They do have a Tai Chi program that's quite good and is evidence-based, gut circuit training, and it either happens in gyms or they have an app or it's online. So again, a lot of nice opportunities there. YMCA also has a lot of wonderful programs for patients, for older adults. So, and again, many of these are their best practices. They're composed of excellent components. People have to get trained to offer them. So again, some really good, good ways to make sure that when you're done with your patient, they're going to keep going. Because what we do not want to do is get into that cycle of patient fell down, I treated patient, I got the patient stronger, patient started walking again, and then therapy was over. But patient never really understood that's just because I'm not there, like they never owned it after. Like they need to own it and continue, because if not, they're going to lose it all. They're going to be at risk for falling again, and the cycle will continue. And if anybody's, well, why do we have these two titles, these two options? This is more of a little bit of a nuance, but the evidence-based programs have been tested in their entirety. A lot of resources have gone in to prove these. So there's fewer of them, and they're not quite as accessible, but they are available. And then best practice programs are, you know, they're very good in a different way and typically have greater access. So why would you want to do this? Why would you want to incorporate this into your practice? It's going to help improve adherence and compliance, because we can only do so much with our patient. And once they're in a group program, there's usually a little bit more accountability, and it also just helps them, because a lot of times we have to discharge them before their confidence is really where it needs to be. Also, if you have a patient who's stable but has some challenging issues or has severe fear of falling, really great opportunity. Like, hey, I'm going to refer you to a matter of balance class. Really great way to make that transition from we're done with therapy to being fully wellness. You know, that's kind of the highest risk time when they're done with therapy and haven't really fully made that transition in great quality. So this is a reference for you. This is in the handout, but it just gives you a listing of all the different programs that are available. These are the evidence-based programs that are related to falls risk and falls risk management. You can see there's quite a few. And there are actually 4 as of now that have been translated to Spanish. All right, so I've got 3 cases, but I'm going to basically talk about the first one, because then I can give you all an update on Otago. So we've got Emma, you're her home health therapist. She's got vision, strength, balance, and some sleep issues. She wants to be social, but she's afraid to go out. So you go through, you've got your objective measures. She's definitely not walking fast enough to do community exercise, so you want to keep it in the home for now. And your job is really to match her with the program that's going to best meet her needs, which means you're having a lot of conversations with her about what she wants. And she's definitely somebody who's appropriate for the Otago exercise program. So, and her motivation is she really wants to get out and start being with her friends again. So she kind of understands that if she does these, she'll be stronger, she'll be more confident in her balance. Okay, so let's talk about Otago briefly. So evidence-based fall prevention program has been around since the mid-90s. When patients do the program as intended, meaning they do the exercises, appropriate exercises for 30 minutes 3 times a week, and when they walk for 30 minutes 3 times a week, they typically fall 30 to 40% less than their peers who are not doing those exercises, and they have far fewer fall-related injuries. So a couple things. There are 17 specific strength and balance exercises. Patient doesn't have to do all 17. The job of the physical therapist is to identify which of those 17 are appropriate, assign them. Once the patient masters them, progress them, and then add in more challenging, some of the more challenging exercises as they get stronger and improve their balance. Ankle weights are critical. Again, going back to the fact we need to challenge our patients. And so there are 3 exercises that require weights. I got to tell you, patients love it. Like once you get past the initial pushback, they really like to see, oh, I'm getting stronger. Oh, wait, I can lift 1 pound. Oh, wait, I can lift 5 pounds. I've had patients get up to like 15 pounds. It's crazy. So don't don't shy away from that. It's really important. And it makes a heck of a lot more sense to a patient than resistance bands, even though they're highly convenient. It makes a big difference in somebody's brain of I can lift 5 pounds versus, oh, I just went from red to green, right? So I also have in here a link to a guidance statement for the Otago exercise program that has all the updates. So y'all can check that out. So here are some things that have changed with the Otago program. When it was originally introduced in the United States, we introduced it just like they did in New Zealand, which was it was a home-based program delivered by physical therapists. And over time, over the last 10 years or so, we've done a lot of research that has shown actually it's an exercise program and it doesn't really matter where it happens. What's important is the patient does the exercises at the appropriate dose and intensity. So we've got great research now that shows you can do the OEP in nursing and skilled nursing facilities as a one-on-one or as a group exercise program, long-term care, assisted living, outpatient, and online. We had a lot of folks move to online and to virtual classes because of the pandemic, and we found great adherence and compliance and great results. So again, it's not so much about where it's done, it's really about doing it. Lots of great data that shows we can do it in a group format. Groups can be led by physical therapists. Groups can actually be led by lay people under the supervision of a physical therapist. Groups can be led by exercise instructors under the supervision of a physical therapist. We've learned that having that PT available to be the consultant or to do initial screening is really helpful, just in case somebody has dementia or has vestibular issues that a layperson or someone who's not trained would be able to identify. So that's the next bullet point. And again, we actually have research that shows that older adults can follow DVDs and get the same results. They can follow an avatar leading them through the exercises and get the same results. And definitely the group delivery model. So there's a lot more flexibility than there used to be. People who are appropriate, pretty much anybody who's at risk for a fall. A lot of really great research actually being done in younger individuals with developmental disabilities, showing that Otago is incredibly effective post-transplant patients. So anyone really of any age who kind of falls into that more frail category. And the folks who are the most frail are going to get the best benefit. The other thing is it's not a forever program. People graduate, like it becomes too easy. And those are the folks that need to move on to a Tai Chi or a Zumba class or something. But as long as it's on their feet, challenging their balance and they're getting that dose. And then finally, the fidelity piece is really, okay, so how do we know it's still Otago? So the way we know it's still Otago is, it's individualized in the sense that the patient doesn't necessarily have to do all the exercises if they can't do all the exercises. They do the strength and balance training 3 times a week for up to 30 minutes, and they do the walking 3 times a week for up to 30 minutes, and they don't change the exercises. You can add other exercises in, but you don't change those Otago exercises. They're done in standing. That's the secret sauce. So, and really that 8-week thing, you gotta get enough time in there. So, all right. So in the interest of time, I've got a couple other cases in here. These are just more application. I got a little ambitious with the amount of stuff I wanted to cover here with you all. So, so you can read through these cases in your notes. And again, they just give you some different ideas of how to manage these types of patients, how to manage them on your caseload, and how to transition them over to the appropriate intervention when you're done with therapy. And again, just some interesting information about technology and technology adoption rates for older adults. So again, a little cheat sheet for you all. And at this time, I will take any questions. So I think what I'll do is I'll stop my share, unless Jenny, you want me to do something different here.
Yeah.
And are questions in Q&A or are they in chat?
That's amazing, Dr. Tiffany. So far, I don't see any QA, but some of them, they raised their hands a while ago. So
Okay.
the question before is about the hands out. So I told them on the chat, there will be handouts as well, and some resources from our respected speakers. But feel free to, jot down your notes. Any questions, guys? And I can unmute you. Yeah, from Laura, you covered a huge amount of information, Dr. Shubert. Yes, that's awesome. Yes, I think Jane has a question. If some of you has some question, raise your hands and I can unmute you. And some can write some questions on the QA, guys. Go ahead. That's really great. And I also put here, Dr. Tiffany, some of the Otago link from the North Carolina, so they can have access. And here we have certifications here. Can they also do some certification internationally?
Yeah, you can't. Well, okay, I'm gonna clarify a couple of things, and so one of the resource center at UNC right now is actually under construction. They're doing some major updates. So and the way we had it done before was you could go through a training and you could, show that you'd gone through the training, but there's not actually a true certification process. So I think that's really, really important. On the National Council on Aging website, that link that I put in the slides, that's a really great place to start. And there's a couple of other resources available to just help educate you about how to implement Otago. So I put in the resource section a link to some different podcasts that are available now that you could actually take for CEUs, and several of them cover
Oh, wonderful.
Otago.
Yeah.
Yeah.
And also Relias, Dr. Tiffany, that's amazing as well. And
yeah, it's really fun. So you can listen to them, and then if you want the CEUs, you can pay $10 and take a post test and get the CEU, or you can just listen. And that way it's evidence-based.
Yes.
So hey, so there's a great question from Rose. If the patient can't do a traditional vestibular test, is there an alternative? Yeah, Rose, there are, and it really is just because, sometimes the whole moving people really quickly isn't fantastic if you've got somebody with dementia. And so there are some different modifications that you can make where you're moving slower, or sometimes just having the person lie on their side and then just having them turn their head and holding the position, and then looking up can sort of give you an idea. You can see the nystagmus. So there are just some little modifications you can make that can make a big difference. And there's some good resources available for that.
Yeah, that's really good. Especially tomorrow, that will be our first topic. We have Dr. Gans for the vestibular rehab. So they can learn more about the basics. And when you say traditional vestibular, what are the basics that they can at least study, Dr. Tiffany? At least the Dix-Hall pike, the different maneuvers that they need to must have at least as a basic.
Yeah. So sorry, is the question what are they, or
at least as a first as a basic, what will be the vestibular?
Yeah. So your Dix-Hall pike, your Epley, the kind of the whole gamut. And what you can start looking at is really kind of like, okay, if my patient can't get the full neck extension, if I can't, what are some changes that I can make? And you can really start looking and observing, and it's amazing. You realize how well trained you are when you start realizing okay, maybe I don't have to do it exactly this way, but I can still get that kind of an outcome.
Yes. And what is the best age according to Donna? What is the best age to start fall screening?
Oh my God, that's such a good question. So the reason why we start at the age of 65 in the US is because that's when Medicare kicks in. I actually like educating people about falls in middle age. We actually have data that shows that people from the ages of 45 to 64 actually fall at the same rate as those 65 and over. They just get injured less. So I actually like to start talking about it younger, and then I start screening whenever I see somebody who I'm a little concerned about.
Mhm.
But as a rule of thumb, I typically, all my patients who are 70 and over, I tend to screen.
Oh, okay. Yeah. I
Yeah.
think more on education is for everybody. False education is everybody. We can do false screening, especially more on the high risk and like 50s and above. Yeah. Yeah. All right. Thank you so much, Dr. Tiffany. And then let's see our last question. What new set of problems would pop out when we would need to treat elderly patients who have undergone lower X joint replacements? From Yambre.
Oh my gosh, that is a whole other conversation. So I mean, then okay, so Yambre, the main thing is like, first of all, depends on where you are, but if you're in the hospital or if you're in the home, have they recovered actually from the anesthesia, if they had general anesthesia? Because that's the biggie. And then from there, making sure that you don't have any issues with delirium, because that's usually a really big problem post-surgery. And then, so basically what I'm saying is, let's make sure that patient is medically stable. Okay. And now we've got to figure out, they're recovering from that total joint, and maybe they are also super weak before. So how do we start that strength training? How do we start getting them in a situation where they can be successful? How can we start doing some modifications? How do we give them some objective measures to achieve while at the same time rehabbing that knee? So I guess what I'm saying is be very holistic.
Yes.
And a lot of total joint replacement and falls management are actually the same interventions.
That's right. Yeah, that's true. Never took anesthesia into account. So thank you so much, Dr. Tiffany. We
You're
really
welcome.
learned a lot from your presentation. And then we just want to check. So check, guys, the resources that Dr. Tiffany shared to us. And then she has also the Relias. We are using the Relias in our company, Dr. Tiffany. So thank you so much. And then
You're
we just
welcome.
want to give some certificate of appreciation to Dr. Tiffany Shubert
Oh.
as our keynote speaker, and for sharing her knowledge and expertise for the Geriatric Rehab Summit 2023. Remember, guys, this is our 4th annual event. And thank you so much. So this has been awarded today, July 28th, if you're in US. It's July 29 now in Philippines. So thank you.
Thank you all so much. Awesome. I really appreciated it. And wow, I know everybody in the Philippines is really early in the morning, and I'm very impressed.